the second day of Navratra celebrated all over India, which marks the victory of good over evil. With the season of festivities having begun, we all are experiencing a breath of positivity back into our lives, emerging out of COVID fear. As promised, IPS Mumbai Navi-Mumbai is back again with its second event in this year 2020. As the secretary of the IPS Mumbai Navi-Mumbai Branch, I feel privileged to heartily welcome our branch president, Dr. Ajit Shetty, our renowned speakers for today, the serene and intellect Professor Dr. V. Rangarajan, the witty and wise Dr. Ajit Shetty, our respected panelists, our very own Dr. Suhasini Nagda and Dr. Jyoti Tembunne, our program coordinator, our editor of the IPS M&M, Dr. Naisargi Shah, IPS Head Office, President Dr. J.R. Patel, Secretary Dr. Rupesh, IPS EC, IPS Mumbai Navi-Mumbai members, other regional branches, my dear colleagues, and my dear students, for this wonderful webinar session for today titled Bruxism, the Unrelenting Risk, a Prosthodontic Eye to Diagnose, Plan and Treat, made to happen by our social media partners, DentistChannel.Online. This topic was particularly chosen, bearing in mind the complexity of the parafunctional entity and its influence on the stomatognatic system. The leading stalwarts, our speakers for today, aim at ironing out the myths and assumptions and guide us to the diligent decision-making, making our patients rehabilitate in a holistic manner. I humbly appeal to all to kindly become members of the IPS and stay tuned with us for our journey of learning and growing. With this promising note, I appeal to our president to deliver his welcome address. Sir.
Thank you, Saloni. I think it was a wonderful preamble for today's meeting. And good morning, ladies and gentlemen. It gives me great pleasure to welcome you all to our second webinar. As you all know, education is a way of progressive life where we imbibe some of the best experiences of our experts. There are many topics, especially in dentistry, which are taken for granted, either due to its overwhelming success stories and which can be consistently achieved. But in contrast, there are many such topics which, due to their complexity or ignorance, are swept below the rugs and the deteriorations are watched in isolated, helpless silence. Indian Prosthodontic Society Mumbai Navi-Mumbai Branch has undertaken to host webinars on such gray areas where experts in those fields, due to their enormous body of work, will share them for the benefit of audience. Today, we have with us two such delightful luminaries, known for their oratory skills, sound clinical work, and powerful teaching inclines. Our own Dr. V. Rangarajan and Dr. Ajit Shetty. The topic is also very scary, like the nightmare on Elm Street, Bruxism, the unrelenting risk. Our gratitude serves for your valuable time for us in spite of your tight professional and family commitments. And to give us company as expert panelists, may I take this opportunity to thank our recognized teachers and prosthodontists, Dr. Suhasini Nagda and Dr. Jyoti Tembunne. Surely today's hostess, Dr. Saloni Mistry and coordinator Naisargi Shah have done a commendable work to make this program possible. Thank you both, and also to my hardworking EC team. Personal thanks to our educational partners, Nitin Doshi from Doshi Marketing, Vikram Vaidya from Bradent, and Prashant Doctor from Alpha Omega Enterprises. And of course, our media partners, Ruben and team from DentistChannel.Online. So have a great session, friends, and over to Saloni.
Thank you, sir. Just give me a moment to share the screen. I now take the privilege to introduce our expert expert panelists for today on behalf of our entire branch, IPS Mumbai Navi-Mumbai. The panelist for today's session is our very own Dr. Suhasini Nagda, my beloved guide, a lady icon in the field of prosthodontics. She is FDS RCPS Glasgow in the Health Professional Education, Philadelphia, USA. She's the Director and Educational Consultant of the CU Shah Medical College, Gujarat. Former Director of Medical Education and Major Hospitals, ex-Dean Nair Hospital Dental College, recipient of the TC White Scholarship Glasgow, awarded Best Poster in Education in Brazil Conference, invited as a speaker at the ADEA Women's Leaders Conference, Barcelona. She's been the past president of the IPS. She's the editor emeritus of the JIPS. Well, her accolades are one a many and endless. Madam, you've truly marked a niche for yourself in the field of prosthodontics, and you have indeed been a guiding light and inspiration for one and all. We are so privileged to have you here amongst us today. Our second panelist for today is Dr. Jyoti Temburne, professor and head of our alma mater, Government Dental College and Hospital, Mumbai, one of the prime dental institutes in India. She is a recognized PhD guide, a chairperson for Fellowship of Oral Implantology, ex-academic council of the MUHS, ex-chairperson of the Board of Students in Clinical Subjects in MUHS, ex-member of Human Rights Commission. Madam, thank you so much for being with us here today. I now invite our moderator for today, Dr. Naisargi Shah, to formally introduce our speakers for today. Madam.
Thank you, Dr. Saloni. I would now take the opportunity to introduce both our esteemed speakers of today's webinar. Our first speaker is Dr. Ajit Shetty. He has graduated and post-graduated from GDC Mumbai. He is Diplomat of Indian Society of Oral Implantologists and also Laser Dentistry, Asian University, Germany. He has lectured extensively and conducted several hands-on courses and clinical demonstrations all over India and abroad on aesthetic dentistry, implants, occlusions, lasers, and practice management. He is, in fact, conducted oration lectures in many of the national and international conferences. He is a founder member and past president of Indian Academy of Aesthetic and Cosmetic Dentistry, as well as Indian Society of Oral Implantologists. He is past professor and head of Department of Oral Implantology, SDM Dental College, Dharwad, Government Dental College and Hospital, Goa, College of Dental Sciences, Virajpet, Kurg, and a visiting professor, Department of Practice Management, ITS Dental College, Ghaziabad. He is holding the Clinician of the Year Award from BITIN. Dr. Ajit Shetty is also on the editorial board of Quintention International. He is in private practice with special emphasis on aesthetic dentistry, implants, full mouth rehabilitation, lasers, TMJ disorders, and occlusion-related muscle disorders. And he is director of Center of Oral Rehabilitation and Education. Our second speaker is, of course, none other than Dr. V. Rangarajan. I think he doesn't need introduction. I'm just putting this introduction so that the budding prosthodontists know that what achievements can be, what all can be achieved in prosthodontics. Dr. Rangarajan has graduated in dentistry from Faculty of Dentistry, Annamalai University, Chidambaram in 1988, receiving the Best Outgoing Student and the Gold Medal, and completed his master's degree in the specialty of prosthodontics from R. Ahmed Dental College, Kolkata in 1993. In 1995, he received advanced training in ceramic technology and dental implantology from Germany and USA. Dr. Rangarajan is the first South Indian dentist to receive the diploma in oral implantology from the International Congress of Oral Implantologists in 2003. He is one of the first in India to complete the fellowship course in TMD orofacial pain and dental sleep medicine conducted by Smile USA and Roseman University USA. in 2018. Currently, he is pursuing mastership in the same. He is an invited speaker on prosthodontics, implantology, orofacial pain, dental sleep medicines at various national and international dental conventions. He has delivered more than 100 keynote lectures and conducted over 100 hands-on dental workshops. He has been a member of Dental Council of India also. He is currently dental advisor, professor and head prosthodontics, Sri Venkateshwara Dental College, Chennai. He is member of Board of Studies, Tamil Nadu, Dr. MGR Medical University. He is editorial board of Quintentions India and section editor, Indian Journal of Dental Research. He is a past secretary cum treasurer of Indian Prosthodontic Society from year 2006 to year 2018. He is a past president of Indian Dental Association Madras branch. He is a council member of Asian Academy of Prosthodontics. He is a founder, secretary and past president of Indian Prosthodontic Society Tamil Nadu branch. Dr. Rangarajan is the author of the very popular textbook of prosthodontics published by elsewhere along with Dr. Padmanabhan. He has been in private practice since 1993 and runs a multi-specialty dental center in Chennai called Identity. With this brief introduction, I would like to hand over the mic to Dr. Ajit Shetty for the first session. Thank you.
Thank you, dear madam. Before further ado, now I think all of us are very, very eager to begin with our first session. So I invite now Dr. Ajit Shetty to begin our session for today, Bruxism, the Unrelented Risk. Over to you, Dr. Ajit Shetty.
Good morning, everyone. Can you hear me? Am I audible? Okay,
Yes,
great.
sir. Yes, sir.
Thank you so much for considering me for this huge honor of being able to address the prosthetic group. And I'm going to go ahead shooting off my mouth about the thoughts that I have in my mind, the questions that keep coming in my mind. And I know that I'm being followed by a very able brother of mine, Ranga, who will take care of all that I have said and keep have ready answers for everything that there will be in my things which I raise questions about. Okay. Now what happened? It's not going ahead. Sorry, my screen is stuck. Lobo, could you
Yes,
help me, please?
Yes.
My slides are not advancing.
Yes. Just a minute, sir.
Yeah.
Okay. Could you please stop your screen share and reshare your presentation?
Stop share and
Reshare your presentation, sir.
reshare. Okay. Am I good now?
Could you move to the next slide, please?
No, not happening.
Okay, just a minute, sir.
Mhm. Whilst we're waiting, we can just keep good teeth and celebrating this tension of technology. Yeah. Sorry, guys, we did set up almost 45 minutes back and everything worked. But technology is technology, right?
Yeah, I think as Dr. Ajit is fixing his program, there's a need to understand why we have chosen this topic today. As I
Sorry,
said,
Dr. Sharad. Sorry to interrupt. Dr. Ajit, I request you to kindly leave the meeting and join once again with the same link.
So, okay, so I do leave meeting. So I'll have to stop sharing first, right?
Yes, sir.
Then
Leave this meeting and
leave the
join with the same
meeting.
link.
On the right side.
Over to you, Dr. Sharath.
Yeah, so as I was saying that nightmares are difficult to live with. As you can see just now, we had a technical nightmare, but fortunately we have solutions in the form of Ruben and his backup team. So similarly, Bruxism has been, as I mentioned in my introductory speech, that it has always bothered us in our practices. Many times we are so focused within our mouth to reconstruct what does not look nice to both patients and to us, both aesthetically and functionally. Then we start restoring them and we ignore the telltale signs, probably not having known enough of them. And when these restorations start breaking down, for example, in my early days, I had cases where patients used to come back with a de-cemented crown, chipped ceramic. There were not too many answers because I did not have a perspective of how to address them. And all that I knew was that if I de-cement it, all that I need to do is cement it back. Till I came to situations where there were root fractures, unexplained by the way, and we had sensitivity issues with vital teeth all across the jaw. And many times patients call up early in the morning when I'm on my breakfast table saying, I have woken up with very stiff jaws. Some of my back teeth tend to meet, but my front don't tend to meet. So there was always a flummoxing situation of how to tackle these scenarios. And sometimes there were simple solutions, just make a soft night guard, give them, buy some time for yourself. But I think now we are into more evidence-based science, where there's a lot of work done by people in the West, and fortunately, a lot of people in our country are doing work on handling situations which have these type of symptoms, which are a headache for ourselves too. And in last 6 months, the reason why I picked up this topic is I've been flooded with people walking in my office saying, I have these type of pains, which I now can roughly conclude that it's out of bruxing, clenching. The other wear and tear features also seen. And I think we have two luminaries, as I said, who will put light on this. Without much ado, if Ajit is ready, I give back to him. Okay.
Thank you, Dr. Sharath. Over to you, Dr. Ajit. You need to once again reshare.
What happened?
So you have to reshare your presentation.
I did that, but I just have a window. Okay. Share screen. Now where's my presentation?
Okay, your presentation, sir, might be, it might have closed. Please open your presentation once again and minimize it.
Okay.
All right, sir. Yes.
Am I on now?
You're on, sir. Can you move to the next presentation slide, please?
I will. Oh, yes, I'm good.
All right.
I'm good.
All right. Thank you very much,
Is
sir.
it possible to block these screen? Okay, I'll figure it. Okay, I'm good. Okay. Good question. Thanks, Sharad, for filling in whilst I was struggling with the technological aspects. What is important is that Sharad has already told you something that bothers him. And I have a lot of experience about a lot of things that have bothered me. And the questions that I'm asking, I wish this was a live audience because there would have been a lot of give and take. But the thing is, what about Bruxism bothers you? This is what is my question to you to consider. Is it just the wear of the teeth? Or are you worried about the patient's constant movement of the jaws, which is moving from side to side or clenching down? Or very often some patients come with complaints about some of the family members who are making that irritating sound when they grind their teeth together, and they say it gets them on an edge. Okay. Are we also concerned about the occlusal forces which are being exerted during this act of clenching or the act of bruxism? And we are also concerned about one other factor is that will our restorations survive? Will they chip off? Will they break off? Will they debond? Will they be dislocated? So there are things that have been some of the factors that I consider which have bothered me and which are also possibly bothering you. Now, wear and tear of the teeth are going to cause them, the teeth to reduce in length. That is going to cause them to shorten. And when it causes them to shorten, there are some other things that are going to be happening. The vertical dimension is dropping. Because the vertical dimension is dropping, there's going to be a definite reduction in the airway space. That's one aspect which we also have to consider, because I think more and more the world is getting aware of sleep apnea, and you and I also, as treating colleagues, need to be aware of the same. Another thing is the pain in the neck. Now, where did that pain in the neck come from other than the philosophical phrase of being a pain in the neck? You will realize that as the patient's vertical dimension goes on dropping, the first thing that will start noticing is that the mandible starts sliding forward, and then the patient goes into an edge-to-edge occlusion, or is also possibly going to go further ahead and go into a pseudo class 3. Is this a skeletal class 3? Answer is no, but because of the fact that there is a drop in the vertical, it is going to result in that mandible going forward. And if you try whilst you're sitting there, try to bring your mandible forward, you'll find something that happens concurrently with that, is that your head also tends to come tad bit forward. Now, when the head comes tad bit forward, you'll find that there's going to be a pull on the trapezius, the scalene muscles at the back, and that is how the pain in the neck feature also is going to come in. Then the pain is obviously going to get to the next level, that is the upper back, middle back, lower back, and it is going to go all the way down to the toes. Now, dentistry, we realize, is a whole lot more than doing, preparations and impressions and then going and breaking crowns and bridges. It's a lot to do with the way the rest of the body is going to be conducting itself, especially the musculature. And you will find that the one-hour dentition is going to tell you stories about which toe or foot, whether the medial side or the lateral side of the foot, the patient tends to get cons. It is all going to be resultant coming from our dental occlusion once we start beginning to chase that in that particular aspect. So I was telling you about the pseudo positioning of the mandible. Let's go on and see what could be the effect on the periodontium or on the teeth. Now you look at this very simply. When there is going to be an occlusal load which is in excess of what the teeth can bear, something that we have just put it under the carpet of trauma from occlusion, what happens? One possibility is that the periodontium, that is the support structure, the gum and the bone, is possibly going to give up, is going to pack up, and you'll find that the teeth which are there are almost intact. There's very little wear and tear. Or there could be another possibility that nature can say, okay, I am going to give a full fight back. In that case, what am I going to do? I'm going to make the periodontium extremely strong. When you look at this patient, you'll find that the calcium deposition, the number of trabeculae which is there in the alveolar bone is going to be enhanced. And then you're going to find bossing, you're going to find tori. Now, when that happens, what happens? The teeth pack up. And that is something which you will see all over the place. When you look at what happens when the occlusion goes wrong, you will see a lot of different features. One of the things that we see very often is abfraction. It took us a couple of years to discover this factor of abfraction, because in the past, I remember doing restorations for these kind of situations. And guess what? The patient came back after a couple of weeks, months, and he came back with the restoration in the mouth. And for those of us who are ancient people in the field of dentistry, if you remember, we tried these kind of fillings with glass ionomers, and we were promised that glass ionomer would be very strongly adherent to the tooth structure. And when that popped out, it took away a part of my faith in the wonderful world of glass ionomers in those days. And then little did I know one thing is that after having done these abfraction fillings, especially at the level of the CEJ, the next thing that is going to help it pop out, or the reason that it happened in that first place, is because that the tooth underwent a constant flexion, because of which the enamel prisms in the CEJ area popped out, and that's where we landed up with the abfraction. So what is the cause? The cause is not that class 5 like looking cavity. The cause is occlusion. So after you finish the filling, the imperative factor is that we have to go ahead and address the occlusion. You have to reduce the occlusal heavy contacts and then go and look at life. You can see some of the teeth which are going to be chipped, and you're going to see teeth which are going to be looking at treated. Now, moment you look at this, oh, yeah, don't not to forget these red arrows here. You see the attached mucosa. You see the way the mucosa and the periodontium is looking completely bossed up. Okay, that means very strong. So when we see the flattened anteriors, the first word that comes into our mouth, because we really don't have any kind of serious training in this, is the factor that, oh, here is bruxism. Okay, that's the first word that comes up. Now, we have to also consider another aspect. Could this also be clenching? There are two things which we really need to know about, because you will see pictures like this all over. You will see deep class 5 kind of abstractions. You see really nasty ones like this, generalized. And when you look at them closely, what do you see? There is no incisal wear and tear. The cuspal inclines are all good and solid. And when they're good and solid, it kind of tells you that the patient possibly is not moving his mandible from right to left and left to right, but he or she must be possibly just biting down, clenching down. And that particular clenching is what is causing this particular lesion. Okay. And that's something which is very classical, which I would like you to look at. Look at this part, which shows this teeth. And how many of us have seen this? Almost all of us have seen it. We have seen that you try to articulate the opposing cusp into that depression. And what do you realize? Oh, it does not fit there. So it has not been caused by any kind of abrasion. Then the next big question is, what caused that lesion to occur in the first place? How many of you must have tried to go ahead, fill it up with some flowable composite? It is almost about maybe zero point 0.7, zero point 0.8 to maybe 1.5 millimeters deep. And guess what? It's easy because there's no prep involved, just possible etching and bonding. But then what did you realize? That it tended to keep popping off. Because what have we not addressed? We have not addressed the occlusion. Now, this is abstraction. And if you now look at the reason that it happens, the enamel prisms in this particular zone, right at here at the cusp tips, are going to be on a cone, which is going to be radiating outwards. In abstraction on the cuspal tips, those enamel prisms are going to just go ahead and disintegrate and come out, and you get situations like this. If it was bruxism, it would be flattened out, okay? So how can we tell whether if it's bruxism or whether if it is clenching? And the next question is that, is it really important to know? When you go ahead and look and go back to Google Auntie today and put down bruxism and clenching, you will find almost all over, everywhere, these things are mentioned, intermingled very freely. There's no effort being made to distinguish the same. Then we have, because of this, we have pain in the head, face, neck region, okay? And I wanted to make the differentiation simply because bruxism is involving a pair of muscles, which is different from that which happens in the act of clenching. Now, if you look at bruxism, it is your lateral pterygoid muscle, which is going to cause the mandible to move side to side. And it is the anterior belly of the temporalis, which is holding those teeth and under light pressure. And that goes on happening for a progressive period of time till the cusp tips flatten out. And when the cusp tips flatten out, then the bicuspid and the second bicuspid, maybe and goes on extending backward, involving a bigger span of the temporalis muscle. On the other hand, when we look at a clencher, you will see that we are involving, the patient involving his masseter muscle, and on the inner side, he is going to be involving his medial pterygoid muscle. So these are two separate muscles. And the reason I'm making this differentiation is because you possibly want to consider this when you are going to be treating either with some kind of appliances, or when you're going to go ahead and give the definitive restoration to find out how you're going to be able to counteract them. These both require completely different orientation. Now, how you have seen patients who come to you and tell you they have a pain at the angle of the mandible. Okay. Now, how do you make out? Is this pain because of the masseter, or is this pain because of the medial pterygoid? Now, masseter is normally easy. I hope you can see what I'm showing you. This would be the muscle. This is my zygomatic arch coming down to the angle of the mandible. And I have very handsome masseters. You can see this. This muscle is my masseter, correct? Now, how do I make out it's the masseter or the medial pterygoid? Put your fingers to the back like this of the patient. Feel the posterior border of the mandible. Tuck your fingers in and palpate there. If the patient says, oh, that's the point that hurts the most, doctor, you know that it is the medial pterygoid which is fired in this particular case, and then that's what you need to take care of. Okay. Let's look at Vijay and see his picture. Now look at what you see, and I wish you could have told me, what do you think this is? On the face of it, all his teeth look flattened from end to end, but realize one thing, that how do I classify him? Is he a bruxer or is he a clencher? Look at the way his teeth are chipped. The labial enamel has all chipped off on the centrals, the laterals, the lower canines and upper canines. And you want to look at this and you ask the patient to do a right and a left lateral movement. And guess what? The anteriors are not coming in contact at all. Now, what do you think actually happened in this situation? You will realize that this man is actually, Vijay, is a clencher. And as he goes on clenching, his teeth are getting shorter and shorter and shorter. And then his mandible starts translating forward, as we discussed earlier. And when it comes forward, now the incisors, the mandibular incisors, start coming edge to edge and then start going into a pseudoclastery. And now what it does, it really shaves off or chips off the enamel on the labial aspect. So now we needed to know that this man has gone in from to be a clencher. And look at his teeth, and you will see that he has got the same kind of facets. You see those facets? Okay, a clear shot view that this man is a clencher. Okay, so this is what we just did. And again, look, how do you recognize a clencher? A simple test would be, look at him or her, take a picture. And when you see the picture, you will realize that the masseter muscle is rather enlarged, and because of which you are not able to appreciate it is partly covering the ears of the patient. This is also a dead giveaway to tell you here is a man or a woman who is a strong clencher. Then we do radiographs. And when you do radiographs, we are doing OPGs, correct? And most standardly, when you do an OPG or you refer the patient for an OPG, what do? We have this habit, which is conventional, is to go ahead and place that small bite platform in between the two teeth. And because of that, there's a notch. And because of that notch, what do? The mandible is brought forward. So the mandible edge of the mandibular incisors and the maxillary incisor and notch are now going to be one. What does that mean? Can you study the condyle effectively in this position? Answer is no, because now your condyle has translated forward and it is now riding on the articular eminence. It does not give me an idea. And if I see closely, I will see here the space is less and here the space on the right side is tad bit more. And this is a case of one of my colleagues. And what he has done is that he has placed 4 incisors, good company, good, everything done well. This looks like everything is fantastic. But next picture that he showed me, believe me, this is the after and that one was the before. This patient has gone ahead and lost 3 very well placed implants. And then you start, he said, like, I can't for the life of me figure out what is it that went wrong. I can't figure out what is it that's gone wrong. So what is the important thing for me to do is that I look again at his OPG and what do I see? Look at his condyle. You see the condylar head is completely flattened out. You look down here at his, there is a pregonial notch here right in the front of the gonium. And what do you see? There's a perfect notch. And why is that notch formed? Simply because of the fact that this gentleman, without having a look at his pictures, I have his pictures, but I'm not bringing them in because I have exactly 30 minutes to do this presentation. The masseter and the medial pterygoid cause that bone to remodel at the bottom. And very importantly, look at this lower left angle. What do you see? You see that it is serrated. And why is that? Because of an extremely strong masseter muscle. And that's what is causing that to happen. So when you look at your OPGs, please do me a favor. Look closely at this. Look at the density of bone. This guy should have been a beginner's case and it should have worked very fine. One more reason that this failed is because possibly when here this implant is touching the natural tooth, here an implant is touching the natural tooth, your natural teeth are touching natural teeth. When you bring the teeth together, there is a difference in the amount that these things can compress together. Natural tooth to natural tooth, there is going to be about 23 to 26 microns of PDL on the natural tooth, 26 plus 26, about 52 microns. Whilst when you look at the back, there is 26 here, but in the implant area, it's going to be barely about 10 millimeter, 10 microns. That means when the teeth come together, there is going to be intrusion of the teeth, and because of which the implants become relatively high. So whenever you do equilibrate implant occlusion, you need to take care of that. Let's look at Anuj. And what do you see with Anuj? You see that he's also showing wear and tear of his teeth. Now look closely, okay? There's something which you want to see. You will see that the teeth are wearing evenly. You will see that his canine here is blunted. His canine here too is blunted. Now this starts putting another perspective on him. You will see that his embossing and all is not really so much, and that tells you some other factors. Possibly you want to now start thinking about one factor. And before I go ahead, look at his canines here. You will see there is no wear facet, but you will see that it is reasonably flattened. Okay. And now look at his incisors. Look at his canine. It's flattened out. Look at his incisors here. You will see there's a certain strange kind of flattening. Now, how do you explain something like this? He is occluding in the back. You will see he seems to have a proper maxillomandibular relationship. Then why on earth is this patient sitting down and moving his jaw forward? Give it a thought, because this is again another aspect which we talked about a little earlier. And what was that? Apnea. When you lie back and the tongue assembly falls back into the nasal, into the oropharynx, what happens is blocks the air from going down into the lungs. Then the compensatory mechanism is that the patient will, in his sleep, move his mandible forward, moves his mandible forward. It takes the tongue, base of the tongue a little bit ahead, because of which the airway now opens up. And that is how they start. When you see excessive wear on the palatal surface of the maxillary anteriors, please think and ask the patient questions about his sleep, whether he is actually breathing well, and the other things that you really need to know. And you will realize that as dental surgeons, we are in a position to recognize people who are sleep apneic, along with the factor that he could be a bruxer or a clencher, and send them for sleep studies, and then put them on the right track. Because remember, one thing is that sleep apnea is something which is the root cause of all the different kinds of diseases, be it hypertension, be it diabetes, or even early neurological disorders and so many other things. So it's a thought. It's a thought, because you and I, when you tell your patient that please go and have a sleep study, and his physician hasn't told him that as yet, you get yourself in a position which is, where patients always turn and say, doc, I did not, nobody told me this, but now I'm so happy that you told me. I'm going to go ahead and have it looked at. I want to share another old case with you. This is Lorna. And when Lorna came to me, she had had about 6 to 7 attempts at having her, composite laminates made on her. Sorry about these 2, 3 pictures, which are a little hazy, but this is a very, very old case. And I wanted to share with it because it has a story. Now she said, I have now researched with Google Auntie, and Google Auntie has said that I should have 10 laminates from second premolar to second premolar, and that will solve my problem because this chipping and everything else will break. So we did her pictures. When you did her pictures, you see something. Start looking for this telltale sign. Look at this canine. it is flattened out. Look at this canine. It has got a proper cuspal anatomy. And I asked my patient to go ahead and show me the way she moves to the right or the left. And sorry, let me see that. Yeah. So what do you see? You see this wear and tear there. You see this thing chipped here. You see that one chipped here. And then when she moves to the right, you see all these things start fitting into one another. Okay. Does she need 10 laminates? Answer is most definitely not. What she really, on the left side, she has a very good canine rise, and there is nothing that needs to be done. So what was the treatment plan? We went ahead and made 4 incisors for laminates for her on the front 4. And on this canine, I actually, in those days, because I did not have technology to support me, I went ahead and made her a full crown. Today, I would make a palatal veneer on that upper canine. So we mounted her case, then we fixed it in her mouth. We went ahead right and left, and you'll see now there is a lot of good ride, and there's absolute clearance. In the protrusive, there were small interferences that needed to be taken care of so as to not cause it to ride on only one tooth. Next big question, is this a case of complete success? Okay, or was there a failure? It was excellent and lasted for about something like about 5.5 years. Then one day she called me and she said, Doc, my lateral incisor popped out. And I asked her, okay, please come in and let me have a look. And when we went ahead and had a look in her case, we realized that now her lower canines on both sides, especially on the right side, sorry, was showing wear and tear. What did that tell me? It told me that on the top, I had an Emax laminate. On the lowest, there was no preparation done, no laminate done, with the end result that my lower canine wore out and the canine rise that I had gotten for her in the first place was lost. And now again, I had to go back and retreat her. I didn't have to take off what I did, but what we do standardly is all the 4 canines, that's the maxillary 2 canines, will get a palatal laminate, and the mandibular 2 will get a facial laminate. And with that, we are able to maintain things for a longer period of time. Uh, a part of this is canine watching, because you look at the canine, it's going to possibly tell you a lot of stories. That's my son, and that's my doggy mafia. Now, this is not that dentally we are only being going to look within the mouth. We have to realize that as a result of what is happening, you will realize that the muscles of the face, because of the wear and tear which is happening in the teeth, are going to start behaving differently. Now, if you look at this patient and you'll see one thing, Anuj will show that his neck, his head is lifted upwards. You look at his left shoulder, okay, it is higher. His head is tilted to the left side. His shoulder is higher. His left hip is higher. Okay, and you see his right foot, it is played to the outside, and his left knee is overloaded. Now imagine once you have trained yourself to start looking at these things, just by looking at the face, you can ask him, do you use your right leg when you want to start climbing the stairs? Which is the leg that you extend out forward? And the patient tells you, my right leg. And he asks, he says, is it right leg? He is going to be obviously, bombed out, thinking, how on earth did uh, doctor even guess that I'm doing this on the right side? So this is something which comes from watching patients. A couple of minutes on splints and night guards. Is there a fight back? There is a fight back, especially with bruxism. Okay, there are a huge lot of reasons for bruxism, and whatever we have done in our practice, and we have so many colleagues who are on the similar track. We first were obviously the textbook answers are different, and our beliefs are a tad bit different. We believe a lot of it comes from occlusion or malocclusion, and then there are patients who are psychologically afflicted, who constitute approximately 5 to 6% of our patients, because we have given them splints and they still show some wear and tear. So when we look at the word splints, most of the teachers in the world only talk about anterior deprogrammers, and many of us have grown up with what is called as NTI devices, those small triangular devices which we fitted on the upper central incisors. Are they the answer for every situation that there is? My belief, my firm belief is no. Is it a long-term therapy? Answer, no. Is it good for 5 to 7 days whilst I fabricate my proper definitive splint? Yes. Would I use them for that? Of course, because it's quick to fabricate, and that's an easy thing. Now we have fabricating in our practice something that one of my students from UK called it the Rio splint, and he says it's removable ideal occlusion. Now, if you look closely at the splint, this is a maxillary splint and this is a mandibular splint. You'll find that everywhere there is a central fossa occlusal context. There's a palatal occlusal line contact. There's again central fossa, palatal occlusal line. There's a protrusive line. There is a right lateral excursion, and you see a left lateral excursion. And if you look at this particular case, you will realize that the right and left don't match. And that is simply because this patient has got an supra-erupted maxillary third molar. In the mandibular case, we often prefer to use mandibular splints because it's far easier for the patient to wear. Unless the patient is a class 3, then we go ahead and give a maxillary splint. Here again, you'll see protrusive right and left canine guidance. Okay. And you'll realize that when you look at this, you will find when you finish that equilibration, this will have an anatomy which is very close to that of our natural dentition. That means there is a buccal incline, there is a palatal incline, and the palatal cusp and the central fossa. This kind of adjustment is not like a Michigan splint, which is just going to have 2-3 contacts on right and left, and it allows it to go. Why do we take the trouble to go ahead and establish this? Quite simply because when my patient tomorrow decides to go to Sharad or to Ranga anywhere, and he puts the articulating paper, and if he sees that the occlusal contacts are on the CFL and also on the POL or BOL in the mandibular, he knows that there is no right to left disorientation of the mandible. He knows that we have achieved stable datum. While to the Michigan, it becomes almost impossible for me to find out. So this is a protrusive, that's right, that is left. And just a couple of tips about, a lot of people say that, yes, yes, doc, I make night guards. And they will tell me, I give my patients soft night guards. You ask me, do I believe in those? I would very firmly tell you, absolutely, absolutely not, because these soft night guards, as you call them, they will protect your restorations fine for to a certain extent. But what we don't realize is that soft guards in the back of the mouth is going to start behaving, or patient starts interpreting physiologically that it is food. In fact, the muscle activity tends to increase a whole lot. And that is something which is what you don't want. So if you're looking at getting patients relief, then you want to go ahead and make hard acrylic splints and then take life from there. That's what's going to be good. So now please stop grinding your teeth or stop clenching, because it's the end of my presentation. Thank you so much for a very, very patient hearing. And if there are any questions, I'll try to answer them. But I'm in the middle of a family wedding. My niece is getting married. I'm not at home. I'm here in Jaipur. And I wish you all the very best. And stay strong during these tough times of COVID, because you have an awesome life ahead of you. And God bless each and every one of you. Thank you.
Thank you so much, sir.
Thank you. Oh, okay. Am I out of the thing? Okay, good.
Yes, sir. So, well, after your session, we clearly realized that your eyes cannot see what your mind cannot think. And obviously, your session has made us realize that for Bruxism, for diagnostic skills, you have to look beyond and you have to think beyond. So thank you so much, sir. We'll come back again for the question answer round. Now we are going to go to our next part of our session. Dr. V. Rangarajan, I invite you to kindly continue with the second part of our session. So,
Thank you, Saloni. I'll just share the screen now.
yes, sir.
Okay, is that fine? Can you see the full screen?
Yes, sir. Yes, sir.
Yeah, just making sure that I can change the.
Yes, sir.
So very, very good morning to everybody. And I am taking over after this wonderful lecture or clinical. It's a very, very clinical, practical lecture by Dr. Ajit Shetty, a good friend of mine for so many years. And he has put in all his, experience into this, and really wonderful to see the problems that bruxism, the consequences of bruxism, and he has, given so many clinical instances of all this. And as always, I am going to speak a lot on concepts, what bruxism is, and less of, and a lot will be on scientific evidence that is backing this bruxism, where we are today, how it started, and, all those things, what is the etiology, diagnosis, and some aspects of treatment, splints. We will touch upon all this. So let's start with about 6-7 years back, when bruxism was defined as a repetitive masticatory muscle activity that is characterized by clenching or grinding of the teeth. As Dr. Ajit Shetty also said, it could be both clenching or grinding, and or even bracing and thrusting of the mandible. Okay, it's just not clenching and grinding alone, and that is specified. So, and that definition classified bruxism into sleep bruxism and awake bruxism, depending on the circadian time. This was by an international consensus group of all the top-notch people around the world, who have done humongous amount of research all over the world. So that was published in Journal of Oral Rehabilitation 2013, and based on this, the next definition came, and the basically the International Classification of Sleep Disorders, ICSD, and the American Academy of Sleep Medicine, and various other external agencies got into this, even the American Academy of Orofacial Pain. And then they defined sleep bruxism in specifically as a sleep-related movement disorder with a yet to be determined multifactorial etiology. The most important thing in sleep bruxism, which all of them proposed at that point of time, this was 6-7 years back, and it is still the concept that is in vogue now. Most important was RMMA. Two things you have to understand: RMMA, or rhythmic masticatory muscle activity. That's what they felt, repetitive and recurrent episodes of RMMA. And most importantly, all this RMMA was associated with sleep arousals. Because anytime you go and look up a literature on sleep bruxism, you will immediately, go into this thing called arousal, sleep arousal, and all that. So just to give you one brief idea about what is this arousal and sleep arousal. So all of you know the sleep cycle. Sleep latency is 20 minutes it takes us for us to go to sleep. Then N1 is 4 to 5%, N2 is 45 to 55%. Both are light sleep stages. N3 is about 20% deep sleep. REM is, of course, rapid eyeball movement. The other three are called as non-REM. And this is about 20-25%. Most importantly, the central nervous system and ANS are highly active. Skeletal muscles are in a hypotonic stage during REM. If this is approximately, each cycle is about 60 to 90 minutes, and then we have about, it again, goes back to the whole thing, N1, N2, N3. So 3 to 5 minutes of NREM, non-REM sleep every night. And every 20 to 40 seconds, what happens is, during this entire sleep cycle, sleep oscillates from very quiet periods, which are called as phase B, to more active ones, which are called as phase A. So you will be sleeping quietly, then 20 seconds later, your brain is little more active. This is called a cyclic alternative pattern. And the active physiologic periods lasting 3 to 15 minutes, that is this phase A. So these are called as arousals. That's what you need to understand. So sleep oscillates between quiet and active ones, and these active ones are the arousals. So what happens in these active ones? Such active periods are windows where the sleeping individual can readjust his body position, reset body temperature, and if any harmful event is perceived, he becomes fully awake. So he is almost like, he can be woken up, he is very alert at that point of time. So you have to understand that the RMMA or the bruxing basically happens during these arousals. Now, what is this RMMA? This is very slow chewing like movements in the absence of tooth grinding. Normally itself, it occurs in about 60% of adults as a normal physiologic jaw muscle activity and shows a frequency of 1 Hz. But it occurs in 80% of sleep bruxing patients, and frequency is 3 times higher and is also associated with tooth grinding sounds in 45%. So this is basically the concept that we are in for the last 7-8 years about sleep bruxism being a sleep related movement disorder. And various movement disorders. One very common movement disorder is Parkinsonism. Something, it's not like Parkinsonism, but it falls under that sort of a category. So what happens now? In about 2018, there was another consensus paper which came by the same group, almost a similar group with top-notch, researchers from across the world getting together at the IADR conference, International Dental Research Conference. And they now define sleep bruxism as a masticatory muscle activity, just a muscle activity during sleep that can be rhythmic. There it was only rhythmic. Here it could be rhythmic or non-rhythmic, and it's not a movement disorder or sleep disorder. And also very important to know, it can happen in otherwise healthy individuals also. It need not be happening only in some diseased individuals. So what was the paradigm shift here? MMA or the masticatory muscle activity is very important. The role of masticatory muscles as a source of clinical consequences is important here. It's a motor phenomena, and we need to look at it as independent of neurological coordinates. That's what this study group has stated. And in an otherwise healthy individual means what? They consider bruxism is not a disorder, but it could be a sign of a disorder in some, and might be a risk factor also for negative oral health consequences in some other people. So basically it is a muscle behavior. Basically it's a muscle behavior that can have different etiologies. It can also be harmless. It can be harmful and sometimes even protective with respect to several health outcomes. How is it harmful? We say, like Dr. Ajit Shetty has said, it causes severe masticatory muscle pain or TMJ pain or extreme mechanical tooth pain. It definitely causes prosthodontic complications. But one thing we are all missing here is that all these harmful things that I have mentioned or is being mentioned here is all multifactorial. Severe masticatory muscle pain, several causes of severe masticatory muscle pain, including myofascial pain is there, and there is many causes of temporomandibular joint pain. And tooth wear, we don't have to ask, much more, many more causes of tooth wear. Most important cause of tooth wear according to me is the hit and slide in centric. That is the most important reason why your anterior teeth start getting abraded or treated, because when the patient closes in centric, there is a prematurity, and then it pushes the jaw forward and starts taking away the anterior teeth. And then of course prosthodontic complications are all there, but occlusion also is important. But remember always that we cannot blame everything on bruxism, because even all these harmful things that are being told as referred to bruxism can be multifactorial and protective. Can you imagine bruxism? Some authors have said that by restoring the patency of the upper airway, it can be protective. And also in some when gastroesophageal reflex, when you have GERD, there is the acid that comes into the esophagus and probably into the mouth also. Now when people brux, they increase their salivation. So this salivation, they claim that reduces the chemical wear caused by this esophageal brux. So understand three things. One, it can be harmless. Yes, it can be harmful. Understand it, that can be multifactorial. Third, we are going one step further, and some of them are also stating that it can be protective also. So understand all this when we are going about rest of the things. Yes, prevalence is though what is reported, I'm sure there is much more than what is reported. Many more people grind their teeth. Prevalence could be much higher. because many of them may not sleep alone, and the bed partner to tell you all these things. And very important to understand is frequency is highly variable. Now, some patient may be bruxing now for 1 month, then he will just stop. He may not do brux at all for about 6 months. He may start again, and he may brux less today. He may brux more tomorrow. So this is something that is really, that we need to understand the importance of all these things. So let's look at the etiology of Bruxism. What are all the proposed etiologies as far as the literature goes? The most important to understand, and I beg to differ with Dr. Ajit Shetty here, is that dental occlusion absolutely, as of today, no longer can be considered. Occlusion or malocclusion can be considered, and there is enough and more literature coming out now, as it cannot be considered as an etiology of the Bruxism. Psychosocial factors, yes, because it has been proven higher levels of urinary catecholamines are there in bruxism. Studies are there. There is some genetic evidence, but the inheritance or genetic markers is unknown. Neurochemicals, L-dopa or clonidine are found to be, less in bruxism. So there is some etiological factor going on about the brain chemicals which could be involved in bruxism. Disorders, ADHD, what happens in children, Parkinson's disease, Huntington's disease, dementia, epilepsy, gastroesophageal reflux, sleep disorders. Any of these disorders could also have a sign of bruxism, or it could also, it's not, we are not saying that, one of the signs and symptoms could be brux. Very important also to understand there are a lot of secondary bruxism. This is called a secondary bruxism because this is called by pharmaceutical agents. A lot of my patients, at least I can say about 5% of my patients who are bruxing, when I have stopped or asked them to go down on these compounds, in fact, you can understand, I don't know if, you need to make a list of this. This is all, there. Alcohol, caffeine, nicotine, amphetamine, selective serotonin reuptake inhibitors, Haldol, which is an antipsychotic, calcium channel blockers is now commonly taken for hypertension, lithium compounds. So all these things could also cause an individual to brux. So you need to find out whether the patients are on any of these also. So it is something like a multifactorial. We should not just keep looking at the tooth and thinking of nothing else. And this is the truth, it's multifactorial, it is centrally mediated with a complex interaction of all factors influencing the autonomic system. And there is enough and more evidence on that. When we look at the diagnosis, what this consensus group has come out now, saying that you could diagnose it in a non-instrumental manner or using instruments. Non-instrumental is, of course, self-reporting, questionnaire. You have a questionnaire in your clinic, you're asking questions, and you are also orally asking the history of the patient. You get some information out of that, and they will write there, okay, my wife says that I'm bruxing, or they will report that to you. Then, of course, clinical features. Dr. Ajit Shetty beautifully talked about masticatory muscle hypertrophy. He talked about masseter. So that could be a clinical feature. Scallop tongue could be a clinical feature. A linea alba on the inner cheek, that mark in the interocclusal line could be a feature. And of course, damage to dental hard tissues, cracked teeth, wear, repeated failures of restoration. All this could be a clinical feature of bruxism. But the confirmed diagnosis of bruxism is only done. Of course, we can't go and tell every patient to go and get a PSG with audio video recordings, but that is the confirmatory diagnosis for bruxism, and that is done with an instrument, and which is called as the polysomnograph. Now, with this in mind, we can grade bruxism as possible, probable, and definite. So possible is based on a positive only self-report, the first one that you saw. Probable is based on a positive clinical inspection, with or without a positive self-report. And the only definitive thing is based on positive instrumental assessment, with or without positive self-report and or positive clinical inspection. Now understand, these are all orofacial pain disorders which need to be differentially diagnosed and eliminated when patient is having a bruxism. So we need to understand that it's just not such a simple entity. You need to go into another specialty called orofacial pain. And now, because of the importance of all these things, orofacial pain is now recognized as a separate specialty in the United States. A few things here: bruxing events and mastigatory symptoms. Now, the relationship between bruxism and pain is not conclusive at all. In fact, a bruxism group without pain, they adapt, actually had more bruxing events per night than the ones with pain. So what happens? A chronic bruxer may come to you with muscle hypertrophy, but he may never complain of pain, because it's like going to a gym and developing your muscle. What is he doing? Slowly he's bruxing, and over a period of 5-6 years, there's no question of any pain. Only probably a new even bruxer, or something else which is overriding on bruxism, that is the only thing that will cause pain. So when a patient comes to you with pain and he says he's been bruxing for 10 years, we need to understand what has changed now that is causing pain. It just doesn't happen overnight. So you are going to the gym, you're doing bodybuilding for 5 years, you do the same thing, you've built it up. Now suddenly you've got pain there. Does that mean that your muscle has become weak? No, sir. There is some other change that has happened, and we need to look into that. Other thing is common thing which we find, that bruxism and TMDs. Numerous report of sleep-related bruxism and presence of painful TMDs Yet no correlation between TMD and frequency of bruxism has been found, and as of date, no causal relationship. That means bruxism causes TMD has been established. Because I was also thinking the same thing, that the moment I heard people come to me and tell me they are bruxing. So first, be careful of joints. See, 5-6 years down the line, your joint will go. You will have this problem, that problem. But no causal relationship as of today has been established. However, there is something. TMD patients may have a propensity to keep a type of hyperarousal level. You saw what is arousal. Hyperarousal level during the night. But that itself, whether it causes TMD or not, is questionable. And as of today, we don't have any evidence to say that it causes TMD. But orofacial pain and sleep bruxism definitely comorbid. The prevalence of orofacial pain in subjects with sleep bruxism ranges from 66 to 84% in different studies. And frequent headaches have also been associated with sleep bruxism in both adults and children. So this entity called orofacial pain is something that everybody needs to understand. Though it is a new specialty, that's why it's an upcoming specialty, because so many of these entities are now coming under the umbrella of orofacial pain. And as you can see, every slide that I'm putting is with documented evidence. So it's not just that I'm coming here and saying something out of my own experience. My own experience was different. I have changed a lot after going through all these kind of programs and trying to understand what is bruxism with scientific validity. As Dr. Ajit Shetty beautifully mentioned, bruxism and OSA, very, very, very important. It appears that bruxism and sleep disordered breathing often coexist and share common risk factors. The clinician has to be cautious in assuming causality. Nobody can say sleep bruxism causes OSA or OSA causes sleep bruxism. Again, that I'm not getting to that. But be aware that they could coexist. So a sleep bruxism patient can have sleep apnea also. And very, very important is, if a sleep bruxism has OSA and you are giving him the splint that Dr. Ajit Shetty showed so beautifully, which is called as the flat plane appliance, then you are going to aggravate OSA, because you are going to retrude the mandible. And the most important thing you should not do in an OSA patient is retrude the mandible. The moment you give your appliance, you're going to increase the vertical dimension. The moment you increase vertical dimension, you retrude the mandible and you will aggravate OSA. So what type of appliance to give when the patient has both sleep bruxism and OSA? We will take a look at that. So coming to the, we saw the concepts now. I hope, we have some understanding about where bruxism is and, where as of today. And of course, what I'm speaking today may not be relevant tomorrow or in 1 year or 2 years time. I am just giving you current information. This whole thing is evolving, and we need to understand, and we need to be, as clinicians, completely be in tune with the scientific data or literature that is coming out. Treatment can be divided into behavioral strategies, medications, appliances, and currently no therapy has been proven effective in treating sleep bruxism. Yes, it has to be a combination. It's just not splint. You should have behavioral strategies. You should have cognitive feedback. You should explain to the patient what he's going through. Explain to the patient about sleep hygiene. Avoid risk factors, as I told you, smoking, alcohol, caffeine, drugs. Control the wake time. Improve sleep habits. Try to reduce stress. And all these things, everything. It's a combination of everything, not just slipping an appliance and saying, okay, go off, everything will be fine. Medications, pharmacological treatment should be considered only in symptomatic, severely affected patients with pain. But remember, only as a short term. This is not a cure. So clonazepam 1 milligram demonstrated, all of us know it's a benzodiazepine, demonstrated a 40% reduction in sleep bruxism in some studies. But as I said, whenever patient comes to you with pain, it has to be screened for comorbidities, because rarely we will get pain because of only bruxism. And what are all the other drugs known to decrease sleep bruxism activity? These are all there. Even botulinum toxin is there. Clonidine is there. So all these things have been documented. But again, as I said, for short-term use, nothing is long-term. So when we come to this oral appliances itself, we can divide them into soft appliance and hard appliance. So over the counter, let's not talk about it. We all know that that's going to really mess up so many things in the mouth, and it doesn't really put the jaw in the proper position. Yes, you can have a full hard appliance, you can have a partial coverage appliance, and custom made soft appliance, we could reposition or non-reposition. Important thing to understand is appliances only protect the dental surfaces, and there is some evidence that they relax masticatory muscles. Exact mechanism is not known, but only thing that they do is protect dental surfaces. They are not a cure for bruxism. Most studies reported a decrease in sleep bruxism activity only in the first 2 to 3 weeks of treatment. It does not depend on what appliance design you use. You use an appliance, soft, hard, anything, there will be a reduction in sleep bruxism activity in 2-3 weeks, and then again the patient starts happily bruxing. That is what the literature says, and we also see that clinically. And obviously the effect seems transitory and is also highly variable among patients. Yes, soft splints do not allow for occlusal prescriptions, less durable than hard acrylic. And as Dr. Ajit Shetty said, it is found to increase masseter and temporalis muscle activity, and may in fact lead to some increased muscle pain or discomfort in some patients. Possible, okay, all these things. So I'm just giving you the flip side of everything. Finally, or the advantages, it's up to you to decide, because nothing is said that, okay, this works or that doesn't work. Hard splints, Dr. Ajit Shetty has beautifully shown you how hard splints should be there. Full coverage, it lasts longer, the occlusal prescription is good, you're having a stable occlusion, stay clean also for a long period of time. When you compare whether I will give a full coverage maxillary or mandibular, whatever suits you. So the disadvantage of maxillary is less retentive. It is in a class 2, it is given. It causes less cheek biting. Mandibular is definitely more retentive, given in class 3. And also less retrusion of condyle, important. When you consider OSA, a mandibular will cause less retrusion of condyle than a maxillary. And it will cause more cheek biting, the mandibular. So full plane, as Dr. Ajit Shetty said, adjusted to provide a stable mandibular posture, basically by creating even posterior occlusal contacts. Most importantly, we do that because we don't want teeth to supraerupt and go and damage the occlusion when the patient is going to remove the splint. That is the most important reason for giving all the teeth, posterior teeth in contact and light contact in the anterior teeth. And also because, it gives him some freedom of not to lock it in MIP. So this is the most widely used, there's no doubt about it. And very well, it has worked well with me. It has worked well with Dr. Shetty, and we can go ahead and give this. There's no problem at all. And this is a good material for us to take a bite or jaw relation. And the partial coverage splints, Dr. Ajit Shetty partial little bit spoke about this NTI-TSS, which is a concept by itself. This is in this concept it says that the bruxism is based on something called as a nociceptive terminal trigeminal inhibition. So this trigeminal inhibition causes the muscles to relax. So it's just this kind of something like a Lucia jig, which is worn and only for the anterior. And this is a concept. So you want to give, go ahead and give this. I mean, nobody can say that don't give this, because at the end of the day, this is also a splint. But what are the disadvantages of a partial coverage splint? Anterior and other segmental splints must be used with caution, as they may allow for unwanted tooth and condylar movements if worn continuously for a long period of time. That's the flip side. You want to give a Lucia jig, go ahead and give. Nobody can say that that is wrong. But I mean, any kind of splint is okay, but now what is the advantage and disadvantage. Now, I would do a mandibular repositioning device or advancement device if I find that OSA and sleep bruxism coexist. So, and routine flat plane appliance will aggravate OSA. So, any of the mandibular applied advancement devices which are used for OSA will work well with these patients also. Now, finally, coming to what are the effects of sleep bruxism on restorations, because finally, let's talk about first, again, absolutely, evidence based. So technical failures, loss of retention, and in this review, definitely technical failures were there in tooth supported FPDs with bruxism, loss of retention and fracture, even biological failures. Metal or ceramic restorations were preferred, but because of ceramic chipping, some prefer gold acrylic, but I don't know whether any, this was in 2011, this article. I don't know anybody will prefer acrylic now, but you can understand that acrylic itself wears away. So as you can see in the next slide, when you look at wear of materials, resin will wear away. So really gold and acrylic is not something that is great. Veneered zirconia also showed chipping on bruxers. There is a lot of promising results on monolithic zirconia, saying that is much better, more tolerant. Again, as I said, lot of good thing coming out. We don't know in the long term yet. Good studies are coming out, and also the studies, all the studies propose that when you do a restoration for a patient with, or if you have identified the patient as bruxism, then go ahead and give a protective occlusal splint for use at night. But as of today, there is no control studies of the efficacy of such a protective device. It has not been published. Monolithic zirconia, as I said, yes, there are studies which say that it doesn't wear or as easily, and it is also pretty kind to the opposing dentition. Again, another systematic review. This is a systematic review, did not favor any association between sleep bruxism and increased odds of failure. So just imagine, it's a diverse sort of evidence that we get. And when we look at implantology, the most important thing, Carl Mesh in his cardinal paper in 2002, he said that on bruxism patients, what will I do? I will place additional implants. I will increase the diameter in the posterior implants. We should eliminate cantilevers. We should give metal occlusal surfaces, and we should give night guards. So what is the literature saying about it? Yes, this review says that it is a risk factor. It is associated with increased mechanical and or technical complication, but there is no impact on implant survival. Doesn't mean that the implants will fail. Implant restorations and bruxism, another a systematic review. Bruxism is unlikely again to be a risk factor for biologic complications, while there are some suggestions that it may be a risk factor for mechanical complications. Again here, implant supported ceramic single crowns and fixed partial dentures were found to have significantly higher porcelain fractures. And they said that when you did not use a protective occlusal device, the fractures were much higher. So there is a lot of literature. In fact, I have read some articles which, as Dr. Ajit Shetty said there is a lot of failure of the implant also. But if you read the fine print there, they say there could be so many other risk factors of other than bruxism which were not evaluated for the patient. That is also important to read the fine print there. But when we look at systematic review and various other things, the jury is definitely out there that there is more risk for mechanical problems rather than biologic problems. A lot of textbooks on complete dentures give that bruxism is a frequent cause of complaint of soreness of denture bearing mucosa. The relationship between oral parafunction, residual ridge resorption has not been investigated. Again, RPDs and bruxism, heavy bruxism may have detrimental effects on the residual ridge, and although this has again not been systematically studied. Just quickly about awake bruxism. Now we are not touching so much because at the end of the day, patient is clenching or grinding when he is awake. So it is more, the causative factor is more or less nailed in awake bruxism. It is more psychosocial, more because of stress. And we could, we could take care of it better easily because we can always ask the patient, you be aware that you're bruxing. All these behavioral things make the patient cognitively aware of what he's doing. We can treat this in a much better way than sleep bruxism. Sleep bruxism is a more difficult thing to get hold of. So just, okay, now the patient, what is the philosophy as of now I will follow? Okay, case one, patient complains of bruxism, comes to me today. He says, I know I can feel I'm clenching, grinding. My wife says, my father says, mother says, what will I do? No pain. He doesn't have any pain. What should I do now? I will protect the occlusal surfaces because I know definitely it could be one of the factors. So I'll go ahead and protect him, give him an oral appliance. Very importantly, before giving him an oral appliance, I'll screen him for OSA so that that increase in vertical dimension that I'm doing is not going to affect his OSA. I will also recall him every 3 months and make sure, that if everything is all right or if pain is coming, we'll keep track of this patient. Now, a known bruxer. Now, this is a patient who's been bruxing for a long time. Now, suddenly he comes and says, Doc, I've been bruxing for a long time. Now, suddenly now I'm having pain. It could be in the presence or absence of tooth wear. It doesn't matter. You have to understand, as Dr. Ajit Shetty said, clenching and bruxism. And he could just be clenching for a long time, which is static bruxism. And now suddenly it has become dynamic. And that could also be a problem. Or very important most of the time is we need to look at systematic factors and make a thorough OFP evaluation. Or if you're not an OFP specialist, refer, because these things have come to a stage where if I am not a specialist in this, I would like to refer. I don't want to keep experimenting with my patients at this level or at this point of time. Again, now, okay, patient complains of pain in the joint area. I notice severe wear of the tooth, but patient is having pain in the joint area. I'm itching to do a full mouth rehabilitation. Now, will a full mouth rehabilitation cure the pain? Absolutely no. First, diagnose the cause of pain again through an OFP evaluation. And better to go for irreversible treatment. Just because I gave a splint and in 3 weeks the patient became all right. And as I told you, enough and more literature is there to say that first 3 weeks the pain will go or there will be reduction in symptoms. But what happens after that? Go ahead and give a full mouth rehabilitation. Patient is paid through the nose for this. And then the pain still continues. You are going to be in big trouble. So as of today, I will definitely not do a full mouth rehabilitation to cure the pain because I think that it is caused by occlusal factors or wear of teeth. So, I had to rush through all this because we don't have much time. So in conclusion, what would I say? The etiology, the jury is still out there, it's still under debate. And it seems to be certainly controlled centrally, not peripherally, definitely not occlusal factors. It is multifactorial and it is evolving. Day after tomorrow or next year, I could be saying something different apart from what I said today. Peripheral factors like occlusion seem to be finding less favor. So never perform irreversible tooth grinding. I see many people even on Facebook, there is some discrepancy between ICP, RCP, and they start grinding the teeth. No evidence, absolutely no. They can do it, but there is no evidence. And why would I irreversibly damage the patient's teeth if I'm not sure that that is going to solve the problem? Treatment need is also based on possible presence of clinical consequences. I've already said that. There are consequences. It could be harmful, it could be harmless, and it could be protective. A splint only protects the dentition, does not cure the problem. Again, clear. OSA needs to be diagnosed in all sleep bruxism patients. And management is multi-pronged, directed towards the tooth restoration protection first, patient education, pain relief. And OFP should be assessed in chronic pain patients. Please understand, no causal relationship has yet been established between sleep bruxism and TMDs. Very good. I will also, prosthodontic restorations when I'm doing, I will also give a protective splint after, I just for as an abundant caution when bruxism is evident. Most important, assess the risk factors. First of all, when we are fabricating restorations or new restorations, stick to occlusal principles. Very, very important. I am not saying occlusion is not important. Occlusion is extremely important for the long-term value or the prognosis of that restoration. Very, very important. You go and give some occlusion where there are a lot of posterior prematurities, and you develop a full mouth rehabilitation. Obviously, your whole restoration is going to be damaged or it's going to break. And very important. So occlusion is very important when you're restoring teeth, even an implant. When we are restoring an implant, make sure it is implant protective. When you are doing a full arch implant prosthesis, make sure it's mutually protected. All these things, occlusal principles, are very important for the whole restoration to function for a long period of time. That is very important. So it's very important for you to understand that occlusal principles. First, check whether the whole thing is correct. The other very important thing is, as I told you in the beginning, the hit and slide. A lot of things happen because of hit and slide, attrition. You go and look up the literature on hit and slide. The moment patient bites on centric, there is a hit, and then it slides forward and removes the anterior teeth. How many ever crowns and veneers you do on the anterior teeth, because of this problem, it will keep breaking. So unless you relieve that prematurity, you're going to have a problem. So understand the totality of all these things, and try to get some kind of training in this subject also before going into and doing anything about changing the bite and changing the occlusion to cure bruxism. So thank you so much, and as always, I am eternally in gratitude to this person, my mentor, Dr. Davis Thomas. And if I had not met him 3 years back, and I would probably not be talking on this, have not even been talking on this subject. And he has drilled into my brain. And the more we learn, actually, we find out how much we don't know in this subject and in this specialty. That is the beauty. And I am still learning. It's a long way to go. And I can't say that, okay, this works, this doesn't work. That's why I didn't want to say what I do. I want to show you evidence and literature, and that's how smart clinicians need to progress at the end of the day. So thank you so much. Wish you all the very best. And if anyone has any queries, since we don't have that much time, you could also email me at drvranga@gmail.com. Thank you so much to the team of IPS Mumbai, and wish everybody the very best. All of you stay safe and take care.
Thank you so much, sir. It was a fantastic presentation, as usual, with your scientific evidences, your abbreviations, which make us look up through what is SB and what is AB and the OSAs and everything. So your depth of knowledge about the subject and the simplicity with which you put forth with the scientific evidence of each and every thing that you spoke about was commendable. We now proceed to the next part of our session. I would now request our panelist, Dr. Suhasini Nagda, to share her valuable feedback. Madam, over to you. Please unmute yourself, ma'am. Please unmute yourself.
Unmuted. Thank you,
ma'am.
Yeah. Thank you so much. I think in a short time, both Dr. Ajit Shetty and Dr. Rangarajan covered a lot. Dr. Ajit Shetty, in fact, showed some cases clinically and highlighted so many important points so easily. And Dr. Rangarajan also went through the evidence, the latest one, right, starting from the beginning. And I would like to say here that Dr. Ajit Shetty, first of all, highlighted that it's not just occlusion, it is also the musculature. He said that the mandible is affected, the back, the lower back, up to the toes, you need to check. He also said about the earlier days when they use the glass ionomer for abfraction and the flowable composites for the, the clenchers, etc. So he highlighted on the things which stayed and which failed. I think one point here we also should add is the erosion part, chemical erosion especially. Dr. Ajit Shetty, in fact, demonstrates the two set of muscles, the two different muscles, the masseter, which works in the masseter and temporalis, which works on the bruxus, and in the clenchers, how you palpate and find out about the medial pterygoid, lower mandible, lower border of the mandible. Then when he showed the case of that first case of Vijay, he also highlighted on the OPG, the importance of OPG and how the wear of the condyle occurs and how you should use these OPGs. It's a useful tool. And also take the history of the patient, sleep history of the patient. In fact, it's very, very important to take the sleep history because many of the patients today are not only having comorbidities, but they're also, having problems of their overweight, and that's the main problem that also causes